Hi everyone, and welcome to our module on pelvic trauma. Pelvic trauma usually occurs due to blunt trauma associated with a motor vehicle accident. And it's especially dangerous because it can lead to life-threatening hemorrhage. There are vessels in the pelvis that can cause a patient to exsanguinate, and as we'll see in this video, it's difficult to control the bleeding in the pelvis compared to other parts of the body. The bleeding in pelvic trauma usually occurs from the iliac vessels. They're usually damaged by pelvic fractures. And the most common source of bleeding is venous plexus bleeding in the pelvis. This happens in about 90% of cases. The pelvis contains lots of small, thin-walled veins that drain into the iliac veins, and they are easily damaged and torn, leading to bleeding in pelvic trauma, especially if there's a fracture. In a smaller percentage of cases, there can be arterial bleeding, and this usually occurs from the iliac arteries. Here's a drawing of the pelvis, and I just want to show you that there are lots of these venous plexus systems within the pelvis. They sit very close to the pelvic bones, and if there's a fracture, they can easily be damaged, and that can lead to bleeding. There are several common types of pelvic fractures. One of the most common types is a pelvic ring fracture. If you look at this drawing of the pelvis on the screen, the ring is formed by a number of different bones, including the ilium, the ischium, the pubis, and the sacrum. This ring is stabilized by ligaments, and so when there is a fracture of one of the pelvic bones, the ring can become disrupted. Either the ligaments can be torn or the bones can detach from one another. And in order for the ring to be disrupted, you usually need 2 or more fractures, and there are multiple different subtypes of pelvic ring fractures that can occur in trauma. The sacrum is the bone in the back of the pelvis. Sacral fractures are also common. And then finally, acetabular fractures involve the acetabulum, which is the socket of the hip bone that the head of the femur inserts into. It's formed by 3 bones, the ilium, the ischium, and pubis, and fractures can also occur here due to pelvic trauma. Some of the physical exam findings that suggest a pelvic fracture are shown in this slide. First of all, if you press against the iliac crest, you can identify pelvic instability when there is a fracture. There can also be tenderness on compression of the iliac crest. In some cases, one of the crests will be protruding, sometimes through the skin, and you can also see misalignment of the legs if there is a pelvic fracture. The identification of pelvic fractures is usually made by a portable AP pelvis X-ray. This can be done in the trauma bay. It's used to identify fractures, and you can use it even if the patient is hemodynamically unstable. You can bring the X-ray machine into the trauma bay and take a quick image of the pelvis and know that there are fractures present. The gold standard test is a pelvis CT. This can be used in patients who are stable enough to go to the CT scanner, and it can identify fractures and also can identify bleeding. There are a couple of ways you can identify bleeding in pelvic trauma. The first one is through use of the bedside ultrasound called a fast scan. I talk about fast scans in the video on trauma basics, but it's an ultrasound probe that you can use to look for internal bleeding in trauma patients in many places, including the chest, abdomen, and pelvis. The problem with the fast scan is it has difficulty visualizing hemoperitoneum, which is blood in the peritoneal cavity, and that often happens as a result of pelvic bleeding. So the fast scan has a low sensitivity but a high specificity for pelvic bleeding. If you see bleeding by a fast scan in the pelvis, then there's definitely bleeding in the pelvis. But if you don't see evidence of bleeding and the patient is hemodynamically unstable, you have to consider that the fast scan could have missed the blood. So when there's a high suspicion of pelvic bleeding and the fast scan is negative, you need to do something called a diagnostic peritoneal aspirate, or DPA. This is where you insert a needle into the pelvis and see if you're able to withdraw blood as evidence of bleeding. And this is used after a negative fast scan in patients with persistent hemodynamic instability who may have pelvic bleeding. If you're able to aspirate 10 milliliters or more of gross blood through a DPA, then that's considered positive evidence of bleeding into the pelvis. In any patient with pelvic trauma, besides evaluating for fractures and pelvic bleeding, you have to evaluate for associated injuries that are common in patients with pelvic trauma. So all patients need a rectal exam so you can palpate for rectal bleeding or wounds. You can sometimes identify bony fragments on a rectal exam, and a rectal exam allows you to assess the sphincter function to see if there's been any damage to nerves associated with the rectum, and then in males you can examine the prostate position as well. Women need a vaginal exam, and then you need to do ureteral imaging in men and bladder imaging in men and women, and we'll talk about these 2 things later in this video. Unfortunately, in pelvic trauma, there aren't many good surgical options to stop pelvic bleeding. The sites of blood loss are hard to identify and to control during surgery, and this is very different from abdominal bleeding. So in the video on abdominal trauma, I talk about how patients are often taken to surgery for abdominal bleeding. That's not the case for pelvic trauma because surgery usually isn't very effective. So the main treatment for bleeding in pelvic trauma is called a pelvic binder. This is a picture of what one looks like on the screen here. It wraps and binds the pelvis and shrinks the volume in the pelvis, and it basically creates a tamponade effect. It doesn't directly stop the bleeding, but the blood pressure builds up within the binder, and that sort of pushes down on those veins so that they stop bleeding. This also stabilizes fractures as well, and that reduces hemorrhage from fracture sites. Beyond the pelvic binder, there are some other techniques that are used to control pelvic bleeding. One of them is pre-peritoneal pelvic packing. This is a skin incision, and then sponges are placed between the peritoneum and the pelvic ring to try and absorb and tamponade bleeding sites. REBOA stands for resuscitative endovascular balloon occlusion of the aorta. This is a catheter with a balloon on it that's inserted into the aorta via the femoral artery, and then you inflate the balloon. This essentially cuts off blood flow to the pelvis to control bleeding. It's obviously not a definitive therapy because it's going to cause prolonged ischemia, but it can buy you time to do other things to try and get the patient stabilized. Surgical stabilization of pelvic fractures can also be done. And then finally, there are techniques by which you can identify bleeding pelvic vessels and embolize them to try and control the blood loss. Moving on, now let's talk about genitourinary trauma, which often occurs in the setting of pelvic trauma. Genitourinary trauma refers to trauma to the genitals or the urethra or the bladder or sometimes the ureters. And the thing to know about genitourinary trauma is it's usually not life-threatening. It can have serious consequences for the patient, like incontinence and impaired sexual function, but usually patients don't exsanguinate or die from genitourinary trauma. And so for this reason, treatment of life-threatening pelvic injuries like pelvic bleeding takes priority over treatment of genitourinary trauma. Usually a genitourinary evaluation is done after the patient has been stabilized. Let's start by talking about injury to the urethra, which almost always occurs in men together with injury to the penis. Men with urethral injury can have blood at the urethral meatus. They can also have gross hematuria when they void. Sometimes they're unable to void. In fact, the injury to the urethra can cause the sensation that they need to void, but they're unable to do so. On rectal exam, the prostate can have an abnormal position if there's damage to the urethra. We'll talk more about this in a minute. And you can also see ecchymoses or hematoma involving the genitals like the penis or the scrotum. Urethral injuries are divided into anterior and posterior urethral injuries. Let's talk about the posterior injuries first. These are usually caused by a pelvic fracture. And the most common area that's damaged in a posterior urethral injury is the membranous urethra. If you look at this drawing on the screen, the membranous urethra is here, just distal to the prosthetic urethra and before the bulbar and penile urethra. And this section of the urethra has rigid attachments that make it highly susceptible to injury in pelvic trauma. And when there's damage to the posterior wall of the membranous urethra, it leads to bleeding into the pelvis, and that bleeding tends to push the prostate and bladder upward. So a classic finding in a posterior urethral injury is displacement upwards of the bladder and prostate, which leads to a finding on digital rectal exam called a high riding prostate, where you can feel that the prostate is being pushed upwards. In contrast, anterior urethral injuries are usually due to direct trauma, not to pelvic fractures. The classic cause of an anterior urethral injury is what's known as a straddle injury. This is the kind of injury that can happen from straddling an object, for example, someone who falls onto a bicycle crossbar. In this type of injury, the bulbar urethra, this section of the urethra here, is often compressed against the pubic bone, and that's what leads to trauma. Bleeding in this type of urethral injury is into the perineum and the scrotum, not into the deep pelvis, so you won't see that upward displacement of the prostate and the bladder, and you won't see the exam finding of a high riding prostate. Let's talk about the management of urethral injury. It's super high yield to note for your boards that if there is a suspected urethral injury, you should not place a Foley catheter because this could make the injury worse. The first step if you suspect a urethral injury is to evaluate the urethra by an X-ray study known as a retrograde urethrogram. This is a very simple study where a saline contrast mixture is injected into the urethra and then a KUB X-ray is obtained. On the screen is an example of a normal retrograde urethrogram. On the left, you can see that contrast is filling the urethra and the bladder. And then on the right is a patient with a urethral injury, and it's very easy to see that the contrast is spilling out of the urethra. The treatment for urethral injuries is to place a suprapubic bladder catheter to drain urine from the bladder, and then surgical repair is usually required, although as I said before, genitourinary injuries are not usually a priority in trauma, so surgical repair of a urethral injury can be delayed if there are other traumatic injuries that need attention first. In contrast to urethral injuries, which mostly occur in men, bladder injuries can occur in both men and women. These are often identified after a Foley catheter is placed. So once you exclude urethral injury, like we talked about in the last slide, a Foley catheter can be inserted. And if you see gross hematuria, that suggests there's either a kidney or a bladder injury. Patients with bladder injury also often have suprapubic tenderness on physical exam. Bladder injury can also be diagnosed by an X-ray contrast study called a retrograde cystogram. The way this is done is you take a baseline KUB X-ray, then you fill the bladder with saline contrast, you take another X-ray with a full bladder, and then you drain it and you take an additional X-ray. Bladder injury will be apparent either by contrast outside the bladder when the bladder is full of contrast, or contrast that remains behind after you drain the bladder. When there's a bladder injury, urine can leak from the bladder, and there are two types of leaks, extraperitoneal and intraperitoneal. And the idea is that the peritoneal lining sits on top of the bladder. So when urine leaks, it can go into the peritoneum, that's called intraperitoneal, or it can remain outside the peritoneum, which is extraperitoneal. Extraperitoneal leaks are the most common type. They're often caused by a pelvic fracture, and these types of leaks usually heal spontaneously. If you place a catheter in the bladder and keep it drained of urine, usually over a period of time it will heal. Intraperitoneal leaks are less common. They occur when there's injury to the dome of the bladder. If you look at this drawing on the screen, if we have an injury around the dome of the bladder here, then urine can leak up into the peritoneum. And when urine enters the peritoneum, it can cause inflammation and peritonitis, so patients can develop clinical features like abdominal pain and rebound tenderness. And because of the peritonitis, intraperitoneal leaks usually require surgical repair. Shown on this slide are X-rays from two patients with bladder injury. The image on the left is an extraperitoneal bladder leak, and you can see that the contrast material is all retained within the pelvis. The right image shows an intraperitoneal leak, and you can see that the contrast material from the bladder is spewing up into the abdomen and filling the peritoneal space. This is the type of bladder injury that usually requires surgical repair. And that concludes our module on pelvic trauma.